I do believe that we are finally making progress in the treatment of acute myeloid leukemia. But I am interested in all of your thoughts, and I'd like to assess your opinion. So are we making progress? Your options are yes, not at all, just an excuse for me to come hang out in Manhattan, or maybe something in between, some incremental improvement for some subtypes of AML. I'll give you a couple moments to answer that question. Great. So sounds like, fortunately, no one in the room thinks that we're not making any progress, though I am enjoying my time in Manhattan. Thank you. Hopefully, during the course of this talk, those 4% of you will think that there is some improvement occurring in the treatment of acute myeloid leukemia. So the learning objectives for this talk are as follows: to identify the targeted therapies emerging for the treatment of acute myeloid leukemia and be aware of the efficacy of these agents. May be dependent on specific mutations, but there are some agents that appear not to be dependent on specific mutations. So by way of introduction, acute myeloid leukemia is a relatively rare disease, about 20,000 cases a year in the United States, and the vast majority of individuals do not survive 5 years. The median age is somewhere between 67 and 72, depending on the literature source. And as Dr. Mesa alluded to as well, in the myeloid diseases, there is significant heterogeneity. And we like to think about it in AML as differences in genetics, clinical manifestations, which lead to alterations in outcome. I find the new targeted therapies quite promising, but I feel very strongly that we will only make real progress when we can better name and define what acute myeloid leukemia is. So as was mentioned during the introduction, AML has been thought of as AML, and I think we need to move very far away from that. Acute myeloid leukemia is not just acute myeloid leukemia. The first case is representative of a 25-year-old with pancytopenia who presents with ecchymoses and DIC. So a clinical concern for acute promyelocytic leukemia. The peripheral blood smear shows bundles of Auer rods and heavily granulated cells with reniform nuclei shown. Cytogenetics reveals a translocation 1517. That is pathognomonic of a diagnosis of acute promyelocytic leukemia and is a very different clinical presentation than the same aged individual with a high white blood cell count, gingival hyperplasia, presenting not in DIC but with tumor lysis syndrome. This time has a normal karyotype, and while both patients have a FLT3 internal tandem duplication, the FLT3 ITD in the second patient, who we would consider a normal karyotype with a FLT3 mutated AML, has a very different clinical outcome. The second patient is expected to have a very poor prognosis, while the first patient's disease is driven by their translocation 1517 or PML-RAR mutation, and expected to have a quite more favorable disease, and the disease is treated quite differently. So how do we approach a newly diagnosed patient with acute myeloid leukemia? Our general medical skills come into play, history and physical exam, with note of organomegaly, presence of skin changes representing leukemia cutis, certainly a CBC with differential in chemistry, and the importance of a uric acid. I like to review everyone's blood under the microscope, a DIC panel, and then a bone marrow aspirate biopsy, including not just morphology, but flow cytometry to help us determine the lineage of the disease, cytogenetics, which help us determine prognosis, potentially affect initial treatment, and the role of stem cell transplant, and then molecular studies. So we have, for some time being, and this sentiment will get repeated throughout my talk, have been looking at specific individual mutations. We are now in a situation, in many of them, in the myeloid diseases, of thinking about next generation sequencing. Molecular studies determine prognosis and the role of transplant, but have also now begun to impact our targeted therapies for newly diagnosed patients. This had been restricted to the avenue of clinical trials, but is not currently the case. Individuals with newly diagnosed acute myeloid leukemia need to be hydrated, consideration of allopurinol or respiricase based on their uric acid and other features of tumor lysis syndrome, and certainly be transfused as needed. All individuals need an evaluation for the risk assessment, both of their biology of the disease and patient characteristics, to start beginning the conversation about allogeneic stem cell transplant. And in our younger patients, a discussion of fertility is required. The overall survival for adults less than 60 years of age is shown in this schema and across numerous intergroup and cooperative group trials. The overall survival for younger adults is very similar. And as was alluded to in the introduction, we have made progress in the evaluation of prognostic factors in acute myeloid leukemia. They were very crude when I was indeed in grade school. Age, white blood cell count, and the presence of an antecedent hematologic disorder was all we had to go on. Then in the 80s and 90s, the realm of cytogenetics became available. And now our molecular genetics, both individual mutations and their interactions, is flourishing and affecting our prognostic evaluation of a patient and treatment decision making. The NCCN guideline panels evaluate this and include both cytogenetics and molecular abnormalities for our assessment of individuals. We still use these crude buckets of favorable risk, intermediate, and poor risk, though even I think in the room all of us would agree there is nothing favorable about having acute myeloid leukemia, and hopefully the chairs of the NCCN AML session would consider a campaign of renaming risk stratification in acute myeloid leukemia. That being said, favorable risk, you can have favorable risk acute myeloid leukemia not just by a cytogenetic abnormality, but in those with normal cytogenetics, the presence of an NPM1 mutation without a FLT3 internal tandem duplication, or normal cytogenetics with a biallelic CABP alpha mutation is favorable, as are the core binding factor leukemias and 1517. So what do we think has resulted in improvement in acute myeloid leukemia? Number one, a better understanding of biology. So the role of these molecular aberrations, we're now able to put patients into better prognostic risk classifications and understanding how the disease grows. We've developed continued improvement in transplant, both understanding what disease characteristics warrant transplant and complete remission run one, and having greater donor availability and refinement of transplant modalities. In addition, standard treatments have been improved, both modifications in standard chemotherapy and the incorporation of novel agents. So the approach to targeted therapy in acute myeloid leukemia, as I mentioned, AML is defined not really just by a name or having more than 20% blasts in the peripheral blood. We now consider it, and the WHO reflects this, that it's defined by cytogenetic and molecular interactions frequently. And that in part, not just with defining the disease that determines the prognosis. This has led to the incorporation of novel agents over the last handful of years in relapsed and refractory patients, but now those novel agents are being studied in newly diagnosed patients. So as I mentioned in the beginning of the talk, I would like to address therapies thought both to depend on mutational complexity or specific mutations, and those therapies thought not to depend on mutational complexity. And I'll start with the first that are not dependent on mutational complexity. There are 4 topics that I would like to discuss. The first is anthracycline intensification, different formulations of 7+3, and I will focus on CPX 351, though Vosaroxin, there is an interesting study, randomized phase 3 study that has been reported. And this was done in patients with relapsed disease. And adults with relapsed acute myeloid leukemia received cytarabine with or without vosaroxin. The complete remission rate was greater, about 30% compared to 16%, 1/6, in those who received vosaroxin, but unfortunately there was no overall survival difference. I should say there was a slight overall survival difference between 7.5 months and about 6 months in the two arms, but it was not statistically significant. So I will come back to mentioning CPX-351. There are also anti-CD33 antibodies and BCL2 inhibition. All of these therapies to date are not thought to truly depend on mutational complexity. So this data is now a little bit old, though I had completed medical school by the time all of this data came out. There are a series of randomized studies of escalated daunorubicin comparing in general 45 milligrams to 90 milligrams. The standard of care prior to most of these studies was either a dose of 60 or 45 milligrams per meter squared. There are two studies that were published in tandem, the ECOG trial and the HOVON trial. The ECOG study was in younger adults up through age 60, showing a complete remission and overall survival benefit of the higher dose of daunorubicin. The HOVON trial was in older adults fit for chemotherapy, and that group found a complete remission and overall survival benefit between those aged 60 to 65, but not older than that, and those who had a core binding factor leukemia. So if you recall, those with a core binding factor leukemia are frequently have a higher degree of sensitivity to cytarabine-based consolidation. And so a sense, again, that even for the most favorable, or perhaps especially for the most favorable types of acute leukemia, that giving higher doses of chemotherapy, whether in induction or consolidation, is important. So CPX-351 is a liposomal formulation of cytarabine and daunorubicin. The company that created the drug has done laboratory studies looking at the right concentrations of the drug in relationship to each other and how they impact the AML cells. And they found the highest level of synergy and the lowest level of antagonism with this ratio of drug. A randomized phase 3 study was conducted between CPX-351 compared to standard 7 and 3 in adults with secondary acute myeloid leukemia. So these were a fairly restricted population, 60 to 75, full-aged individuals who had either prior cytotoxic chemotherapy, an antecedent MDS or CMMOL, or the diagnosis of AML with myelodysplasia-related changes. And those individuals were considered secondary AML. There was an improvement in overall survival of 9.5 months compared to 6 months, and an improved event-free survival. The toxicities between the two arms were similar. So that's one option of a standard chemotherapy, or a manipulation of standard chemotherapy. I would say that my thoughts on that is that it's a bit incremental improvement, though it is, there was a statistically significant improvement in survival. So CD33 as a target. CD33 is not a new target in acute myeloid leukemia. The newest CD33 construct is a stable dipeptide linkers that enable uniform drug loading of a pyrrolobenzodiazepine dimer that cross-links DNA, resulting in cellular death. As a single agent, the CR and CRI rate was approximately 41% in both relapsed and refractory patients, with a higher remission rate in those who were treatment naive. So that data as a single agent was quite promising. That prompted a combination study with hypomethylating agents, revealing a complete remission or complete remission with incomplete count recovery, or complete remission with still low platelet count of 58%, and a median relapse-free survival of 7.7 months. So those results are a bit higher than we would expect with a hypomethylating agent alone, and has prompted a randomized phase 3 trial. The final agent that does not appear to depend on mutational complexity is BCL2. So BCL2 is a target, and that is inhibited by ABT199, or a BCL2 inhibitor. ABT199 now goes by the name of venetoclax, which is a small molecule inhibitor of BCL2. In inhibiting BCL2, it leads to initiation of apoptosis and cellular death. There's a phase 1b trial presented at ASH this past year, combining the BCL2 inhibitor venetoclax with a hypomethylating agent, and the overall complete remission rate of 35%, with an additional 35% of individuals attaining a complete remission with incomplete count recovery. So a response rate in that study of 71%, again, higher than what we would expect with a hypomethylating agent alone. At ASCO this year, the same agent was combined with low-dose cytarabine, with a complete remission with incomplete count recovery rate of about 54%. These responses were also seen in patients who had prior hypomethylating agents. So when we think about what mutations are important in practice today, i.e. what mutations we should be sending in an individual with newly diagnosed acute myeloid leukemia in our practice, those include FLT3, NPM1, CEBP alpha, and c-KIT. As I mentioned previously, the FLT3 ITD is an unfavorable prognosis. It is relatively prevalent with a 30% incidence rate. The NPM1 without the presence of a FLT3 mutation is considered of favorable prognostic relevance, and a biallelic CEBP alpha mutation is again considered favorable. The prognostic role of c-KIT is still unclear. In the 821 core binding factor leukemia, it's unfavorable, whereas the data is a bit less clear with the inversion 16. So I'm now going to turn to the role of two groups of novel agents that are dependent on specific mutations. Those are FLT3 and IDH. I'm going to like to start with a case, again, to wake you up. So Deb, a 52-year-old woman, presented to her primary care doctor with a week of fever and generally feeling fairly crummy. Because of the persistence of her symptoms, her primary care doctor drew a CBC, revealing a white blood cell count that was markedly elevated, 196,000, and a hemoglobin of 5.7, platelet count of 80. She was instructed to present to our emergency room, and in the emergency room, her exam was relatively benign. She had some scattered bruises and some mild gingival hyperplasia. She underwent a bone marrow evaluation and was diagnosed with acute myeloid leukemia. Her cytogenetics were normal, and she had a FLT3 internal tandem duplication by molecular studies. So what is FLT3? FLT3 is FIMS-like tyrosine kinase 3. It is a tyrosine kinase that promotes proliferation and blocks differentiation. FLT3 is present in hematopoietic cells uniformly. It is overexpressed in the majority of AML cases, but is mutated in about 30% of acute myeloid leukemia. There are two major forms of the mutation. One is the internal tandem duplication, which is the bad one, the one that we know has prognostic relevance. The other one is the tyrosine kinase domain mutation and occurs at the activation loop. That mutation is not known to have the same negative prognostic influence. Folks with a FLT3 internal tandem duplication frequently present with an elevated white blood cell count and have a worse prognosis, mostly vis-a-vis an increased risk of relapse and therefore resulting in lower overall survival. There are a number of FLT3 inhibitors that are in development. There have been a series of single agent studies and combination studies, and as much as I would like to tell you about each and every one of them because I'm very passionate, I will limit it to what I think are the most exciting and the most far progressed. So our patient enrolled on a clinical trial with midostaurin. She attained an excellent response and underwent a matched sibling stem cell transplant. This is the schema of the trial that she enrolled on. This is a large study conducted through the CALGB, or now Alliance. Over 3,000 patients were pre-registered to study, and about 800 patients were randomized on trial. This is a large randomized study that Rich Stone presented at ASH this year with very impressive results. The complete remission rate was slightly higher in the midostaurin arm. But what's most remarkable about this study was the major difference in overall survival seen. The midostaurin arm had a median survival of about 75 months, where the placebo arm had a median survival of 25 months. And so the major take-home message from this clinical trial was that midostaurin improved the overall survival when added to standard chemotherapy, with consolidation and maintenance in newly diagnosed younger adults, and represented a new standard of care. So back to our case. Deb has no major transplant-related complications, but unfortunately at day 130, as her immune suppression is nearly off, her disease recurs. So the question is, what would you offer her at this moment? Great. I love to see that the majority of individuals chose a clinical trial. Unfortunately, at that time, there was not a clinical trial that she was eligible for. She was treated with a combination of sorafenib and Vidaza based on data that had just been presented by Farhad Ravandi and colleagues from MD Anderson. She had an outstanding response to treatment and then underwent a donor lymphocyte infusion and maintenance sorafenib. But we've learned a lot since Deb first presented. We've learned at ASH this year that those individuals who are able to obtain sorafenib post-transplant in the context of a retrospective review had an improved survival compared to those who did not receive sorafenib post-transplant. So sorafenib acts as a FLT3 inhibitor in addition to other tyrosine kinases, and appears to have an improvement in disease-free survival and overall survival when looked at post-transplant. There are also a series of newer FLT3 inhibitors that are more potent that have been studied, one of which is ASP2215, also known as gilteritinib. The median duration of response in these individuals with heavily pretreated FLT3 mutated disease was 111 days, with a median overall survival of 218 days. This data has led to a randomized study that's ongoing in relapsed and refractory FLT3 mutated AML. There are numerous settings where FLT3 inhibitors are being studied and have been studied, and this outlines that. So I've mentioned mutations that are of increasing importance that I'd like to focus the top of which is the IDH mutations. So IDH, or isocitrate dehydrogenase, is important in that it catalyzes oxidative decarboxylation of isocitrate to produce 2-HG, or alpha-ketoglutarate. This kind of harkens our time of thinking about the Krebs cycle. It's hard to believe that that data has come back, and we are now anxiously thinking about the Krebs cycle. So IDH is known to be mutated in about 10% of acute myeloid leukemias. They confer a gain of function resulting in production of 2-HG, which is 2-HG drives multiple oncogenic processes and results in impaired cellular differentiation and the development of AML. There are 2 IDH inhibitors that have been developed where there is a substantial data that has been presented. And the first of which is the IDH1 inhibitor. There are 2 isoforms of IDH, IDH1 and IDH2, and AG120 is the IDH1 inhibitor. And these are patients, the vast majority of them are heavily pretreated, and the overall response rate of 35%, with a median treatment duration on this study of 2.9 months. A bit more patients have been treated with the AG221, which is the IDH2 inhibitor, As of September of this past year, 209 patients have been treated, with still 66 remaining on study. A relatively well-tolerated agent with an overall response rate of 37% and a median duration of response of 7 months. This data has led to a randomized phase 3 study comparing AG-221 to conventional care, and that study is currently ongoing. So in summary, standard induction and consolidation therapy is generally unchanged. However, 45 milligrams is not a standard, and the standard doses of daunorubicin are either 60 or 90, up to age 60 to 65. It's still not clear to me, and I don't know that it will be, if 90 is equivalent to 60. Cytogenetic and molecular studies are critical for risk stratification, understanding of pathogenesis, and applications of treatments. And there are now numerous agents that are being studied in different phases of AML. Novel agents appear to be resulting in real benefit, though I would like to stress the importance of randomized data. A lot of the data with the newer agents that I presented is still just single-arm data. So there are a couple of practice-changing treatments in acute myeloid leukemia, and 2 of which have happened over the last decade. The first is the daunorubicin intensification that I spent some time discussing, and secondary, the use of FLT3 inhibitors, now with the advent specifically of midostaurin. I'd be happy to answer any questions.